Hi there, welcome to, I believe we're at the 11th module already for perfusion and clotting. And this is your instructor, Colleen Hargreaves, and I'm happy to be meeting with you online, even though I do like to have that face-to-face time as well. Very, very important that we have that balance. So as we begin, remember, look at your learning objectives because the chapters in Lewis from 31, 32, 33 have a lot of content. This is also something that you're going to be studying next semester. So this is really an introduction and getting, kind of halfway through the material, and then you're picking up the other half as you advance. Also, Module 11 has some really good in the Evolve resources for you that we want you to plug into to just make this as easy to understand as possible. So as we start, just remember a lot of it is reviewing of anatomy, so please do that. We can't be good educators to our patients if we can't break it down for ourselves. So we will be going over, and I'll be reinforcing especially the arterial and venous circulation, and knowing that the deoxygenated versus the unoxygenated or unoxygenated, oxygenated. Sometimes you hear it like that. You might hear one is the deoxygenated, so unoxygenated. It's terms that are interused, okay? So with the blood flow, just remember, it's coming from the venous to the right side of the heart and moving through the lungs and getting oxygenated and then coming out the left side. That's why you'll hear it referred to as left and right. Very important to understand the process of that blood flow, what's happening. And you've already had some beginning with arterial blood gases, so you know how that can change minute to minute, and the heart has a lot to do with that. All right. The other important thing is to know your valves, the four main valves. And this is further on down the PowerPoint as it gets to the EKG and kind of rhythm interpretation. We'll focus in on that a little bit more. But very important to understand the major valves. So the four valves, all right? So we're talking about the aortic valve, the pulmonic valve, the tricuspid valve, and the mitral valve. All right, so those are things you might want to circle. Do the little circle thing here, right? Pen. All right, so right here, that would be your top part of your heart, the tricuspid, and the mitral valve are considered like the bottom part of the heart, even though they lay not too far from each other when you really look at that, right? So review these things, and it'll help you be able to, when you're actually doing assessment, know what you're listening for and knowing the location. Coronary arteries and veins, as you listen to people going for cardiac catheterizations, you'll often hear them reference the coronary arteries. Now that's when our heart is at, we have systole and diastole. So it's important to understand systole and diastole. Lub-dub, what's happening? Lub is systole, dub is diastole. So that's when the coronary arteries are getting fed. It's during diastole. So that is an important aspect to remember. And that's why having a rich blood supply and full, coronary arteries that are able to be as open as possible is very important to the muscle of the heart itself. Okay, so that's important for you to know. And also the bundle of His, where we have part of the blood, if that gets interrupted, that can also create dysrhythmias. So besides blockage of the coronary arteries that we often refer to as, a major cardiac event, myocardial infarction, MI, right? We're also saying, but there's also parts of the heart that are responsible for the conductivity of the heart. So that's all circulatory. Okay, so if we don't feed the areas that are in charge of something, they fail. So that's why it's very important to understand that aspect. And here we are at the conduction system. So when we're looking at the conduction system, and later on we'll be looking at that a little bit more, this is all what we're looking at when we put somebody on telemetry. When we're monitoring the electrical part of their heart, we're saying, what is happening? Does it have the normal signature that it's supposed to have? Okay, and that will relate to where the pathology, where it's failing. So when you look at the pathology in the conduction system, it should line up with that electronic signature. So right here, this is the electrocardiogram. Very good to know the basics of this to start, getting comfortable with this. I will give you some, samples to play with, and it's very important to just really dive in. You can create homemade kind of even EKG rulers with a index card. I'll show you how to do that. But you really just want to start to say, how can I look at the rhythm of the heart and feel real comfortable with it? So some things you do have to commit to memory, and I'd say the P, Q, R, S, T, U, you do. All right, so just know as we look at those things, what they mean. So if I was going to have you in class, I might say, well, who works in telemetry or who has had some opportunities? I'd say, okay, the P wave. What does that signify? Right? So that's important to know, because the P wave is really the atrial contraction. That's representing what's happening there. And just shut that for a second. All right, so committing that PQRST to memory is important. Knowing words like depolarization, which really has another word for contraction. All right, so that's the activity part. That's when all the energy is being released, and that's why you have a P wave. Obviously, when somebody's flatlining, it makes sense when we say there's no life there. Okay, there's no activity going on. Then you have the QRS, so that's ventricular depolarization. So that's a bigger waveform, because that's representing that whole heartbeat, that blood flow that's coming out, that's just been oxygenated. And then it follows with the T, and the T is important to know because that represents repolarization. Okay, and you kind of say, well, what is it? What's repolarizing? The ventricles. So that's why that's kind of a large wave. If we didn't have that, you'd kind of say, well, because that blood is heavy, it's got weight, it's got density, and it's coming in and it's filling up those ventricles. So the P, the atrial repolarization is not as significant, and it's probably happening during the QRS. That's why you don't really see it. But anything that's going on in the ventricles is always more dramatic. Just know that. Anybody who's ever seen a VTAC or VFib, you'll say, yeah, it's hard to ignore. All right. So as we come, so just look those over and know that now we're moving towards understanding blood flow, and perfusion is another word for blood flow. So don't let that throw you. Tissue perfusion. Anything that's not skin is considered tissue. What kind of tissue? Muscle tissue, right? Bone tissue, whatever we put under the microscope, you're saying, well, what kind of tissue is it? And that's why cardiac, knowing the heart is a muscle, is very important to know that holistically as a nurse, because perfusion is very important to muscles, or they cramp, right? They spasm, as well as rest, kind of ebb and flow. We can't overtax muscles. We also want to make sure that we're nourishing muscles with proper nutrition. So muscles are one of the first to complain when something's out of balance. You have to remember that. Those cramps, and the heart is not an exception here. Sometimes things are related to those things that are just kind of common sense measures versus lifelong accumulation of, contributed to coronary artery disease, where the coronary arteries are narrowed. So things can affect the heart besides lifespan things, like coronary artery disease. Okay, so stroke volume. This is a concept I want you to now take in if you haven't heard of it before. I'm expecting that you know what contraction of a heart muscle, systole, and diastole, relaxation. That's a fundamental concept. But now you're getting up to stroke volume. What is that? Okay, now stroke volume is really a combination of really looking at someone's cardiac output. All right, so it's the amount of blood that's pumped by each ventricle in 1 minute. Okay, calculated by the stroke volume times the heart rate. So that's a formula. So when you look at it, you're saying, if I'm thinking the cardiac output should be normal between 4 and 8 liters a minute, okay, what is that? How do I determine someone's, how do I know how that's happening? So first of all, you wouldn't be able to know someone's stroke volume unless you had proper diagnostics, but a heart rate we know, right? We can check someone's heart rate. So we know that in a normal adult, cardiac output is maintained in the range of 4 to 8 liters. And then depending on the body surface area, it adjusts to the body size. So again, a normal is 2.8 to 4.2 liters per minute per meter squared. So that's why there's some math involved here. But all you really need to understand is that simple formula, which should be coming up on one of the slides here as we move through it. But it's in your notes section too, which just refers to it's cardiac output equals stroke volume times heart rate. All right. Now also concepts such as preload, contractility, afterload. What do these things mean? So, the volume of blood in the ventricles at the end of diastole, that's preload. So we're saying, okay, what has been left in the ventricles? All right. Afterload, peripheral resistance against which the left ventricle must pump. So if we're not able to empty those ventricles thoroughly, that's not good. So the preload is the volume. There might be a volume issue going on, right? That's raising blood pressure, that kind of thing. But afterload is also the resistance. So if we have any kind of aortic stenosis or a problem, that's going to create that blood flow to back up. So it's important to understand that the definitions of these things, like preload determines the amount of stretch placed on the myocardial fibers. Okay, because like I said, you're running in a marathon. Wow, that's a lot of blood flow going along. Okay, so the preload can be increased due to the number of conditions such as aortic disease and hypervolemia. So hypervolemia. All right, but the contractility can be increased by epinephrine and norepinephrine released by the sympathetic nervous system. Increasing contractility raises the stroke volume by increasing ventricular emptying. So these are some concepts that you really want to think about as that's why the fight or flight response. We have a neurosystem that is going to trigger heart rate, right? So if somebody's anxious, that's why we have to really try to work with people to keep them as calm as possible, especially when they are at a high cardiac risk. We don't want that risk going wild, so we have to be careful of that. Afterload, okay, that's the peripheral resistance against which the left ventricle must pump. And afterload is affected by the size of the ventricle, wall tension, and arterial blood pressure. So if the arterial blood pressure is elevated, the ventricles will meet increased resistance to ejection of blood, increasing the work demand. Eventually the result is ventricular hypertrophy, an enlargement of the heart muscle without an increase in cardiac output of the size of the chambers. So Very wordy, but that's really saying how it's important for us to understand that anatomy gets affected over time if people have underlying conditions that don't get corrected, okay, which could eventually end up leading to an ineffective left ventricle, all right? So we have structures and functions of the cardiovascular system. This is the time now you got to think globally, not just the heart, but you're thinking, okay, what are arteries versus arterioles, veins, venules, and capillaries, okay? So we know that arteries are very important to the body because it brings all the oxygenated blood, except for that pulmonary artery. Again, that's the backwards thinking, but the pulmonary artery actually is what leads into the lungs, and it comes out the pulmonary vein with the oxygenated blood. So it's otherwise throughout the body, any artery that ever gets hit is going to be losing oxygenated blood, which is pretty serious. It's one thing to have a vein where you're losing a lot of blood. That's not good either. That's, could lead to hypovolemia, but you're not going to end up with as quickly as an arterial. Arterial is much more serious. So the veins carry deoxygenated blood back to the heart. The small branches of the arteries and veins are arterioles and venules, respectively. So they all branch out smaller and smaller and smaller to the cellular level. And blood circulates from the heart into the arteries, arterioles, capillaries, venules, and veins, and then back to the heart. So it's just this constant cycle, and it's very important for us to understand on the cellular level. It's critical that people are being evaluated. Even things like anemia, it still is a deficiency of oxygen to the cell. So if someone has something wrong with their blood, that is going to impact their whole body, even from a cellular level. So these are things why you have to think small sometimes versus large. But the body does have an amazing way of adapting to less than ideal conditions. So that's where we have to be mindful. All right, so looking again at the artery, the difference between the artery versus the vein. And right here, you have extra muscle built in, thick, muscular, elastic middle. So wow, arteries are pretty flexible. They're made to last for a while. Okay, the thin middle here, the endothelium, they both have an endothelium, outer coat, but the only difference is the arteries have a muscle fiber. So that's something to remember. That's a lot of your NCLEX like to check on if you remember that that's the major difference. That's why they hurt too. When you do an arterial stick, you're literally sticking through muscle, and muscles are just known to be sensitive. Sorry about this. I have to shut off my emails that keep popping up. Okay, so we did talk about how, we have the autonomic nervous system. Do we have control over the autonomic nervous system? I was going to ask in class. I'd hope you'd say no. Okay, we can't really control that. And that's where our sympathetic nervous system versus parasympathetic, and how, again, you have to remember, is rest and digest, right? So rest is your parasympathetic. I always think para, like paradise. Sympathetic is really the more active, all right? So yeah, rest and digest. So we want to have a good balance of those things. Fight or flight versus rest and digest. So your fight or flight is your sympathetic nervous system, and your parasympathetic is your rest and digest. Just want to make sure I'm clear on that. All right, so we also have things that affect the regulation of our blood supply due to our autonomic nervous system, which I just mentioned, the baroreceptors and chemoreceptors. So if I said, well, what's a baroreceptor? These are things found in the carotid sinus, and they are there to, if there's volume overload, they send information to the brain, okay? And this will temporarily inhibit the sympathetic nervous system, which actually will almost kind of override it at that point, so that the body's almost forced to slow down and have less of a response to it, like less of a panic response. So that's a good thing. The chemoreceptors are located in the aortic and carotid bodies and the medulla. Okay, and they're also capable of causing changes in respiratory rate and blood pressure. So if someone is having oxygen, and that's really more your gases. Okay, so when we say chemoreceptors, we're talking about really your gas exchange is very much affected by that, versus the baroreceptor, more the volume, the blood volume. Okay, hopefully that makes sense. And, so that's why it's really important we understand what blood pressure is trying to, what are we trying to achieve by monitoring blood pressure, okay? And another good thing just to look at here for a moment. So now's a good time to look at the basic definition. What's a systolic blood pressure? It's the peak pressure exerted against the arteries when the heart contracts. All right, so that's why systole, systolic, it should start sounding the same. Versus diastole or diastolic. This is the residual pressure in the arterial system during ventricular relaxation or filling. Okay, so I'm reading that. That's just a straight definition. BP is usually expressed as the ratio of systolic to diastolic measure, right? And we definitely want to keep people aware of, what's normal and what's ideal. And sometimes what's normalized is actually pre-hypertension. Like our country, when we look at it according to, against parts of the world, there are some people who never have hypertension. They never experience it. And so we know there's ways to keep our blood pressure down. But when you live in a society where we're very much driven, there's that dynamic of stress, which are external stressors that we put on ourselves, that this is kind of a modern dilemma, hypertension. All right. So that's why it's important for us to understand what affects it and what we should be really aiming for. And what we should be aiming for is more ideal, not what's normal. Because what's normal most of the time is, like I said, pre-hypertensive. So usually a little lower than 120 and a little lower than 80 is really what they want. I always say just shave off 5, even though manually you're not going to hear 115 over 75. But you'd say, okay, as long as it's under, like, if it's a 118, 116 over 76, 80, 76 or 78, great. That's good. That's when you'd want to tell somebody you're right where you should be, ideal, perfect. There is a point of getting too low of blood pressure, so that's where we'd have to talk about that. But you'd have to really say what is the person's norm, and that's why we always have to establish baseline with people. But on this slide, I want to point out BP equals CO times SVR. What are we talking about here? Part of that is, again, dealing with the cardiac output. So when we know cardiac output, stroke volume times heart rate equals cardiac output. Okay? So how much blood you've got, how fast you're pumping it. Okay? That, now just think of it in the sense of what is SVR? It's systemic vascular resistance. So how is the body handling that? So BP is really a reflection of how the body is handling that, changes in our stroke volume and heart rate. Okay? So that's why some people start to climb and some people don't change. All right, the people that are climbing, we have to get concerned about, especially when there's a widening. 120 over 80, that's 40 millimeters of mercury difference. When it starts to get larger, that's called like a widening pulse pressure. That's associated more with aging, but that's also meaning you're getting more arterial stiffness too. So think of that, systemic vascular resistance, SVR. Doesn't that sound like stiffness to you? Doesn't that sound like there's a problem going on? Now, sometimes it's, somebody has changes. We're talking about if we're looking at somebody's baseline that's changing, right? Because we know blood pressure fluctuates, and that's why we have to really create the right environment to do it correctly. And we'll talk about that later. So at this point, you just really want to understand the anatomy of what you're doing. So when you're doing a blood pressure, what is it that you're actually trying to achieve by monitoring a blood pressure. That's what we're talking about now. And also knowing what devices are considered reliable. Now, I like this picture because this woman has her palm up. She's laying with her arm extended, palm up. If you notice, her arm is at the level of her chest, and that's what you want. It should be like level to the heart. And person should be relaxed and probably sitting there for a good 5 minutes. And the nurse could actually sit down and do this too, but you know, she's handling it well. And she does not have to support that arm because the arm is being supported by a table. Okay, that's perfect. One thing you can't see is the woman crossing her legs, because we'd have to say, don't cross your feet or legs, right? So setting it up properly, knowing the right equipment to use, very, very important. And the blood pressure is measured by auscultating for sounds of turbulent blood flow through a compressed artery, and this is termed Korotkoff sounds. So I do have a website that will simulate that for you, and I'm going to get that to you so you can play with that a little bit and make sure that your judgment for hearing is correct. And that's just takes a lot of practice so that you really trust what you're hearing. And also your technique is very important. Okay, so we have also automated devices, but you have to be careful with those too. You have to really follow this. This one's not showing you the picture correctly, but you have to make sure that arm is supported, and many times even having the other arm that's not being tested support the arm, and have, like if you're putting it on a wrist, and really just keeping it at the level of the heart. Otherwise, it's all over the map. You're not going to get a consistent reading. I've gone into homes where sometimes blood pressures, digital, especially when they first came out, you couldn't be near a dishwasher. It would pick up vibrations, probably a vacuum either, anything that was close by. And this one woman always used her kitchen table. So I said, okay, let's move to the dining room table. You're far enough away, and make that your new place for checking. Because a table is ideal. That's really good, no matter what device you're using, whether it's manual or electronic. Sometimes the electronic can be very sensitive, in the hospital especially. All right, so be careful of knowing that. That's why the manual backup is very important, because before you call a doctor, you want to make sure that you're letting him or her know that you checked it manually as well. Because unless you can make sure that machine is functioning perfectly, which you don't have any guarantee of that, but you'd want to check it manually. Also, for checking, for titrating medication, you don't want to be using, an automated device for titrating something, especially long-acting medication. I try to point out that the electronic devices were created really for monitoring under emergency situations or very intensive care kinds of situations. So we're talking about people coming in maybe with an active bleed or getting blood, or in the OR, and they're intubated and they're being really monitored minute to minute. It's really close monitoring. Those things are great. But when it's like twice a shift and you get an abnormal, you better back that up with a manual, because you're going to start to shape care based on something that could be faulty. And that's why a lot of nursing homes have actually taken them off the floors, because there was little judgment being used. People were not using their training and judgment. They were following a machine, which can have an error rate. They don't perform perfectly. So very important to keep that in mind. Okay, so as we move along, Dopplers, usually in the lab, we try to give you access to one. And if anyone's had a baby and they put on the fetal monitor and you hear that swish, 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 it's the same kind of thing. It's just a portable handheld that you put it usually in the distal pulses in your feet. Usually you're looking to check the dorsalis pedis, right? Post-tibial pulses, because you want to make sure that circulation is not impaired there. All right, so that's why they're often used after surgeries, if someone's had some kind of fempop bypass, or they're diabetic and you're worried about that, you're worried about claudication or some kind of, you see a difference in extremities, it's a nice tool, and most units have one. So if you have access to one, please start practicing with the use. You do, before you put it on the skin, you have to use a little conduction gel. So just like they gel you up when if you've been able to see someone go for pregnancy, obstetric kind of examinations, for fetal monitoring, you always have to use conductive gel or they don't work. And you have to clean the machine and the person after using them. Okay. All right, so in here, there's just some other information that's good to know. I did mention the pulse pressure. Okay, so the difference between the systolic and the diastolic blood pressure is normally about 1/3. So again, if you do the math on that one, 120 over 80, if we said that's normal, right? The 40 would be a difference of about 1/3. So that's why when they say a widening pulse pressure is not a good thing. And that's good for you to remember. Jot that down. It's 1/3. So if you said 40, 40, 40, that's 120. So that's what the systolic, there shouldn't be much more than 1/3 of a difference. Otherwise it's widening. The other is the mean arterial pressure, and this is the average pressure within the arterial system that's felt by the organs, and is often referred to as MAP. All right, so that's systolic pressure plus 2, so you're doubling the diastolic pressure divided by 3. So that's kind of a unique formula. So when you look at that formula, just remember that at the hospitals, oftentimes you'll see that in the units when they're doing the electronic blood pressures. Sometimes it'll read out a MAP, but it does need to be over 60 millimeters of mercury. The MAP needs to be greater than that, or it's an indication that perfusion, the organs are being underperfused. So when is that most important to really be monitoring? And that would really be during procedures or surgery. So again, it's one of those things that a little too much information for the floors, but you just know that it's, if you're working in a specialty care unit or intervention radiology or cardiac cath lab, those things start to become important, that you're maybe including them in the sheets. All right, so now as people age, we know that cardiovascular disease risk increases over the age of 65. And it's very important to know that it's also where you live in the world. So the Framingham study, which was in the Netherlands, compared, countries, and we know that people can live and have less of that, but we're going to have to really change a lot of the environmental factors and lifetime behaviors if we want to see a change in that. So research does support that. Okay, and it's good for nurses to understand that, know that. And sometimes people do get the lucky card with genetics, so we can't judge people because the genetics do have a big play in what creates some of that too for people. All right, so these are some other factors that definitely put somebody at risk for cardiac disease. Okay, these are all age-related changes, so read through those and know that that's probably things that you've already observed. We know the orthostatic hypotension, that could be related to a couple of things. So besides the medications, we have to say, what else is contributing to that? And this slide does point that out. So the postprandial is an interesting one as well, because now you're looking at the blood flow is shunting, from the extremities. That's why sometimes we get cold after eating. An older person complain of that. That's probably because their blood flow is more working on digestion. But if it starts to impact their blood pressure and you see a change, 20 millimeters of mercury where it changes, that's when you have to be careful that this person may be at risk for falls, right? So we really want to watch people after meals. It's kind of like the old adage we used to say, wait an hour before going back to swim. And that's kind of like at the geriatric settings. It's the same type of thing. They're going to monitor them and watch them and not really try to keep activity levels down within an hour after meals. And that's not always easy to do. Okay, so now we're into the assessment of the cardiovascular system. It always does start with a subjective. You have to talk to people. Again, we have to know their personal history, their family history, their lifestyle habits, medications, all of that. And you really do have to be prepared, because once you get into the objective, which is your assessment, people may not point things out, and you'll start to see scars where pacemakers usually end up, or, ooh, they have a midline scar down the middle of their chest, and they forget to tell you, because in their mind, that's no longer a problem. So, no, I don't have any heart problems anymore, but they just say I don't have any heart problems. So we have to be careful to not just listen with our ears, but listen with our eyes too, like as they're telling us stuff. Be careful. And don't be surprised by that. Assessment is also knowing how someone's coping with stress, because again, we have the rest and digest, right? The parasympathetic nervous system. We've got to really work on that, because otherwise we're making our body even more stressed than it needs to be. That's why, stress management, it's all about that. It's all about getting that parasympathetic, we got to give ourselves a little paradise, go to that little happy place. Really need to do that for our heart's sake. Okay? And then there are genetic risks, and you just have to know that some of them are quite serious, from coronary artery disease to cardiomyopathies. Suddenly, all of my male relatives die before they reach age 40. It's probably due to this autosomal X-linked dominant mutation. So, because that's tough. Cardiomyopathy, you can survive it if it's caught, but if it's not caught, you'll just die. It's like an abrupt, the heart just will stop. So these are things we have to keep in mind. Also, objectively knowing how to approach somebody for cardiovascular assessment. You have a stethoscope. That's all you need for this. And so you can practice, find that person at home. Come on now. Let's do an inspection, right? Which is a visual first look, and then the palpation, auscultation. And so that's something you can practice at home. All right. When we're looking at the palpation, so in here, that second one, it's really palpating all the pulses. So this here is explaining to you why we have to know where the pulse points are. Typically in the hospital, it's usually the distal pulses we check, the dorsalis pedis, I said before, posterior tibial, or post-tibial, sometimes people say, they just shorten it. Popliteal, femoral, okay, radial and ulnar. You have two on both sides, but we check the radial because it's stronger, it's easier to feel. But if you had a Doppler, you could check both if there was any kind of compromise there, any kind of perfusion compromise. Your brachial. Now, your brachial is not always easy to palpate, but some people you can palpate it in adults, right? But if we have a good radial, are we worried about the brachial? No. If we have a good dorsalis pedis, right, or post-tib, are we worried about the popliteal? And the answer is no. So that's why really the distal parts are your friends, and then carotid, you only check one side at a time. You're never going to, massage it. That'll create a dysrhythmia. And also, even in the chest wall itself, you can inspect for heaves, which are just kind of like seeing heartbeats, movement in the chest, which really we shouldn't really see, not in a powerful, strong way. The carotid, visually, you're also going to look for any kind of distension. Carotid, when we see that happening, then we know that they're engorged, the carotid arteries. So that's part of the inspection. In this area, remember that you have a scale for checking pulses. They're absent. 1+ is weak, 2+ is normal, 3+ Okay, did they just run around the unit? What happened? Did they just come back from physical therapy, really pushing themselves? All right, then let them rest for 15 minutes. Come back and check again. Okay, so everything has to be related clinically with what's happening. You don't want to just assume something. Also, knowing, that the way a pulse feels, okay, is that's why we always refer to it feels more like a tapping, and it should not be like a thrill. There shouldn't be any kind of a buzzy feel. And if anyone's had a chance to go to see somebody with hemodialysis, you'll know that a thrill you can palpate over the AV site, and it's almost electronic current under your fingers. It's a most unusual feeling. Okay, a bruit is that kind of whoosh sound that you really should not normally find. But in an AV, a positive bruit and a positive thrill are good. But in the carotid, they're not good. And you can hear sometimes a bruit in the carotid arteries. But how you'd have to do that is listen on one side at a time, and you'd have to make sure that the person kind of holds their breath. You might say, sir, I'm just going to listen with my stethoscope for a moment. Can you take a breath for me and just hold it? And then just listen for like maybe 2 beats. Okay. You could breathe out. Or take another deep breath for me and just hold it. And you're listening another 2-3 beats. Okay. So you have to take on each side in order to say you've assessed that and it's normal or otherwise. This part here, assessing the when we do the cardiac assessment, where you really say, okay, now we have to listen to heart sounds. Anytime you're going to be giving a cardiac medication that may slow the heart rate, whether it's a beta blocker or a calcium channel blocker or digitalis, anything like that, you have to listen to the heartbeat, and it'll be right here, the point of maximal impulse, mitral valve, apex. Remember, those are all interchangeable terms. So the mitral valve could be referred to as the apex or the point of maximal impulse. Okay, so know that it's sometimes you'll hear it referred different ways. Now you'll see out there in Pinterest land and anywhere where they have nursing tips for listening to the first 2 heart sounds, the aortic and pulmonic, AP, versus the tricuspid mitral. Sometimes they'll say ape to man, AP to man. It's just easy to remember. I didn't learn it that way, but when I did hear it that way, I could see how that's helpful for some folks. So sometimes there's little mnemonics you might use to help you remember. But the aortic is in the second intercostal space, and this picture is very good for pointing that out. So when you're up by the clavicle, right, that first intercostal space is right under that, and then the second. So you could actually feel your own come on down on the right side, and that's the only side that you have the aortic. Feel for your sternum, and you're going to be right there. So you're putting that stethoscope right on the second intercostal space of the right sternal border. And that's how it's referred to. And you're listening with your stethoscope. Okay. Now, some people say, well, what part of the stethoscope should you listen with? So think of the bell picking up the low frequency sounds is recommended because many times, even for doing blood pressure, sometimes it's recommended because if someone has a very low blood pressure, it's rumbly, you're going to hear it more distinctly. Same thing with heart sounds. Heart sounds can be difficult to hear, and so having a little bit of knowing what part of the stethoscope might facilitate that better, that's why it's good to know. Other than that, they do make a lot of stethoscopes today that it doesn't even matter. So just follow whatever stethoscope you're using, and then usually you can start to get good at knowing what's normal. And really, that's what nurses need to know. So I'm glad I said that. We need to know what's normal. So S1, S2 is what you're listening for. So right here, just remember, that's the second intercostal space of the right sternal border. Now the opposite side for pulmonic is the second intercostal space of the left. Erb's point, I'm going to get back to that in a second. Tricuspid, we're in the fifth intercostal space, so is the mitral. So you're both in the fifth intercostal space, but this one's on the right sternal border, and the mitral valve is considered mid-clavicular line. Okay, so that's why you have to say, oh, I'm in that space, but now I just got to move it over, come down. And usually when you place it that way, it's going to work. But not everybody anatomically will fit perfectly into that picture. I just want to say that. But either way, so practice on people that are easy, kind of a normal size and shape first before you get to maybe something that might be more challenging. Now, Erb's point. Okay, so why do we have to mention Erb's point? Erb's point, when I said S1, S2, you have to say that S1, lub, all right, that is the sound of the heart down here. So here, you thought I was going to point up there. S1 is down here. Okay, that's the ventricular depolarization or contraction, right? I'm going to try to say it the same way. And up here is S2. Okay, so there you're listening for different sound. So when you're down here, S1 is greater than S2 up here. So whether you're listening on the tricuspid or the mitral, a normal is S1 is greater than S2. When you're listening aortic or pulmonic, the normal finding is S2 is greater than S1. But at Erb's point, S1 and S2 are equal. So that's why a lot of physicians or practitioners, you may see them come in, and all they do with their stethoscope is put it into just that one intercostal space below and listen for Erb's point. And if S1 and S2 are equal, they don't really need to go any further. That's in their mind. But as nursing students, we really do want to learn to listen, because you'll find things. You'll find people with artificial valves, mitral valve stenosis, all kinds of things. And it's really cool when you get good at that, and you can say, so hone those skills, even though you will see people do those little shortcuts during physicals. So as we go through this chapter, just remember that auscultation is a practice, and cardiologists are excellent, and people who work in cardiac units are usually better, especially intensive care cardiac. But when we're auscultating, just know that your stethoscope, sometimes depending on what you're listening for, that's why I was saying with abnormal heart sounds, the bell is helpful, but with normal, the diaphragm is helpful. So S1, S2, as we just talked about, generally you don't have to flip it over to the bell side because they're considered high pitch sounding. And just remember, S1 is lub, S2 is dub. So you're hearing from the bottom of the heart first. That should just make sense from looking at that diagram. S3 and S4 are different scenarios. They're low intensity vibration, but generally, S3 it's because of decreased compliance of the ventricles during filling. S4 is usually caused by atrial contraction. It's a vibration of the atrial contraction, and it precedes S1 the next cycle and is known as an atrial gallop. So depending on where it hits, and I do have a website that'll give you better examples, because it's easier to understand it when you're hearing the examples than to try to figure it out. And some are referred to as Tennessee versus Kentucky. So S3 is usually thought of as Kentucky, and S4 is thought of as Tennessee. So you could always think, if you're coming from north to south, you'd have to come through Kentucky first, maybe, before you get to Tennessee. I don't know if you want to remember S3, S4, but they each have different pathologies. But you will often hear that referenced to try to understand the cadence and the sound that you're listening and hearing. Okay, now I will give you some examples for looking at cardiograms, and you're not going to be responsible for, performing an electrocardiogram, but we do want you to start to be just aware of things called murmurs, and there's 6 points. Usually it has to be pretty loud, like, to 6 before you maybe could hear it as a student. Anything less than that would really take some expert ears, and that's why we have things like echocardiograms to really see what's going on in the valve. The friction rubs are usually easier to hear, almost like sounds that you would hear in the lungs, scratching kind of rails type crackles, because of, but it's around the heart, so it would just be in a different distinct location, friction rubs, right? So that's why you're hoping to not hear any of that stuff. You don't want to hear any friction rubs, murmurs, or S3, S4. You're just really looking for normal. So anytime it's outside of normal, that's when you should really grab somebody to verify your work, especially in the beginning, or ask the patient, do you have a heart murmur? You might, if they haven't shared that or that's not in their record. Sometimes they forget to share. Might have gotten worse over time too. The cardiac biomarkers, these are important to know. Years ago, this is all we could use were the creatinine kinase, and people, look at this, it would rise in 12 to 24 and return to baseline in 12 to 48. So that meant overnight hospitalizations. People were in the hospital sometimes up to 3 days to rule out an MI because they were getting ischemic, but it wasn't enough to create the infarct yet of the heart. Like, it was, partial blockage. And, before there were cardiac catheterizations, sometimes people would be put on a nitro drip. You rest them, do something to reduce the inflammation of the body, maybe hoping that might correct itself. And sometimes it did. Medication management alone made a big difference. The troponins, on the other hand, we have people in the hospital now, and they can be ruled out within half a day. So they don't even need to stay overnight anymore if it's a negative workup. So that was a big change in practice. And the only downside to that was people did not get to stay in the hospital long enough to really address maybe what brought them there. So we have lost the teaching that we had in the 80s and 90s for really talking about cardiac health and stress management and just dietary. All of that is lost. I've seen people fighting with the nurse because they want to go out and have a cigarette after their cardiac catheterization. So a $25,000 procedure, and they have no incentive to change their behavior. So now that the troponin is the one of choice today, it's the biomarker of choice, you just have to really remember that it's a very small measure, so anything, it should be under 0.03. So 0.03. So if you just think about, a good way to remember is to think it's, because most people know today that 0.08, 0.0, it's like today they have to put the 0 before it. 0.08, less than that, right, is they want people's blood alcohol level. They don't want people out driving. So if you think of the troponin, just think, okay, it's 0.03. It's got to be under that. So it's even half of the blood alcohol level. So maybe that'll help you remember that, because we know that people who abuse alcohol also have a very much higher risk for cardiac events of all types and sizes and shapes. Okay, so maybe connected to that. Otherwise, know that we have other indications of inflammation in the body: C-reactive protein, homocysteine levels. Sometimes people monitor these as outpatient to see if their inflammation in their body is increasing their risk for an event. Maybe they're trying to do it naturally and they're really keeping an eye on that, because there has been a lot of research saying that those things do markedly climb just before a cardiac event. as well as knowing your numbers. We talk about knowing your numbers to your triglycerides, cholesterol, phospholipids. How do we know we're doing okay in that area? And we'll talk about that a little bit more ahead. But knowing what's normal in those ranges is important for you to know. Okay? And I have some good handouts I'll give you. And for testing too, if somebody does have that hereditary where their cholesterol is high, but it's, well, how is it high? Because you're adding together the HDL, LDL, to get the total cholesterol. So sometimes people actually have high HDL, which is good. That's protective. But, it's a ratio issue too. So if some people have a hereditary form, they may want to monitor it to see if what kind of lipids they actually have. So they have other panels too that'll see if the type they have are more dangerous than others. Okay. And so just remember, some people say HDL healthy and LDL lousy. Triglycerides are also lousy. But I always usually say triglycerides are usually high in people who have liver impairment or have abused alcohol, probably for a good many years. That's usually an indicator right there, because it's kind of connected to carbohydrate too. Your diabetic may have elevated triglycerides. LDL, we usually indicate that to more of a, saturated fat kind of thing can make that rise. But then there are some hereditary factors that have nothing to do with dietary. So just know that. But we do know to raise HDLs, exercise. Triglycerides will lower if you're with exercise. But HDLs, it's also, walnuts, healthy omega-3s. That's important to know. And salmon, things of that nature, having good vitamin D levels. All right. And, we can see the heart. That's why a chest x-ray is really important before any procedure, because you can actually see the heart. If it's super enlarged, you can catch that. You would never want somebody to get cleared medically if they have an enlarged heart, right? Or hypertrophied heart. So you have to think of hypertrophy. That could be seen. That could be seen on an x-ray. So if they don't have a baseline, then they'd have to do further investigation to figure out if that's new for that person or that's a known. That happens with athletes too. Sometimes you have young athletes that get cleared medically and then they have a sudden heart attack on the football field or whatever sport it is. And that could have been prevented just with a chest x-ray. So that's why at every age there comes a point when you're grown to the full, you should have a chest x-ray just to get a baseline. I'm more for that, especially if you're physically active. I've known many runners and people that had things picked up inadvertently, and they could have died just out running, and they were very fit, but they had some valvular issues that were undetectable until they had a chest x-ray and it showed that their heart was like 2 to 3 times bigger than it should be. It's pretty dramatic, but it's, artificial valve replacement corrected the problem. They've had to, monitor it on and off through their life, but saved their life, and they lived a very healthy, normal life after that. Electrocardiogram, very standard today. Anybody comes in, we're going to get that, because that's only showing real time though. That's not showing, what happened 5 minutes ago or what's going to happen 2 hours from now or 2 days from now or 3 days from now. It's only real time. Okay, so we have to know that, but it could be significant for an evolving event. Echocardiogram, again, that's our standard for really a gold standard for looking to see the anatomy of the heart. You can't really see the anatomy of the heart without a good echo. And we have things called TEEs, which are excellent. The transesophageal echo, I've helped assist with those. And they're really excellent visually. It's amazing. When you come up here and you see if it's an incompetent valve, and you see the flow of the blood literally coming back out of the valve, like it's not going through, because when the door shuts, it's coming back through. It looks almost like a blowtorch. That's how each bit of blood. So when you think about that, that's why the clot formation is very high risk for somebody who doesn't get that corrected if it starts to get, get worse. Okay. So just know there are different ways of checking heart health. We have things too, like, IV medications to dilate coronary arteries and stimulate exercise. They do have ways of helping someone get their heart checked without putting them on a actual treadmill. Okay, so you have the physical treadmill performance and nuclear medicine, stress thalliums. We used to use those, mugga scans, and a cardiologist is right nearby when that's going on and reading it right off the spot. They can actually get a lot of data, the same almost as a cardiac cath, and it costs considerably less. I mean, if it's $500 to have that versus $25,000. So again, our population needs to understand the cost of things are overly. We use certain diagnostics too much, and it's hurting our healthcare system. So just know we have other ways of checking heart health. Okay, even MRIs, CTs. Okay, looking at and that's really just the takeaway. Just know that the cardiac cath, yes, is the one that we definitely want you to be familiar with. Are there some things you can see with a cardiac cath that maybe you can't see with other things? Well, one of them would be the percentage of occlusion of an artery, and Medicare requires actually that to be recorded before a stent could be put in. And a normal study, and this is kind of scary, for blockage is 50%. So it usually has to be greater than 75 before Medicare will pay for a stent. So that's part of the issue there, and some things are reversible. Again, coronary artery disease is reversible. We've known that since like 2000. So for over 20 years now, we know that it is reversible. It was Dean Ornish, Dr. Dean Ornish actually was the one that published a book, Reversing Heart Disease. But our society still loves to get these coronary artery testings and stent work, and yet we know that many times people have to be restented, and it doesn't have a lasting effect, and it has a very high price tag. Okay, but we also know there are certain things that they could be very life-saving too. So there's still more research out there, but most of us just can avoid that scenario, especially in younger years. Maybe somebody who's more heading towards 70s, 80s, they may end up needing that. But again, unless there's a strong family history, most of us should not need a coronary cardiac catheterization until we're in our older years. Okay, so that's, and that fractional flow is also reflecting the amount of blockage that's in the coronary artery. So these are things that they can find out. So that's it. So I'm going to let it go because this was a little over an hour. I was trying to keep it lower than that, but trying to be as comprehensive as I can be for you. And it's a great topic. I love talking about this. So again, talk to you again soon. Thank you very much.